May I ask you some root value? Tell me the root value of radial nerve first. What is the root value of radial nerve? As the posterior division of all the three cords, that is the lateral, medial and posterior cord, joins to form the posterior cord, alright, and radial nerve is a continuation of this, alright. So the radial nerve root value will be C5 to T1, that is all the roots are involved in the formation of the radial nerve. Similarly, medial nerve by its medial root and lateral root, this also contains all the roots of the brachial plexus. So this will be also C5 to T1. Got my point? So the lateral pectoral nerve will be from upper cord, from lateral cord, that is C5 C6. Medial pectoral nerve will be C8 T1 because it is from the medial cord. Alright, medial cutaneous nerve of arm, forearm, all will be what? C8 T1, and the continuation of lateral cord is lateral musculocutaneous nerve. So it will be C5 C6 or C5 C6 C7. Got my point? You should remember first considering the roots, then the trunk, which trunk it is forming, then the divisions, where these divisions are going, then you will be able to identify memorize the root value. Got my point? It is not that much tough. If you go on drawing the simple structure that I have drawn, schematic structure, and put the root values, right? Okay. Now, perhaps you have read axilla. You have read axilla? There are three processes how we can study the axilla. Number one, you can go by the walls. Alright, that is the anterior wall, posterior wall, medial and lateral wall, right? And you can identify the structures related to these walls. Number two, you can take the neurovascular bundle, either the neural bundle or the vascular bundle. Got my point? The second attempt is to identify the neurovascular bundle and then divide it into either neural bundle to identify first or the vascular bundle to identify first, right? You will see in the axilla, I will show you, I will show the dissection when I get a class of that part, alright. I will show you. You have seen the M pattern, that is, this is the lateral cord, this is the posterior cord, this is the medial cord. So the communication from the lateral cord and the medial cord is joining. This is musculocutaneous nerve and this is continued as ulnar nerve, right? Now, if you take this pattern, this is lateral cord, this is the medial cord and this is the median nerve. If you pull the median nerve portion looking at the M pattern, this is not an M pattern, this is the lateral cord, this is lateral root of median nerve, this is medial cord, this is medial root of median nerve, and this is a continuation of median nerve. So if you hold this middle of the M pattern, this is the middle of the M pattern. I haven't drawn the posterior cord correctly, alright. This is the posterior division or joining of all the lateral, medial and posterior cord. Alright, I have not drawn the branches, alright. That is the axillary, radial, right. Now, if you pull this median nerve, right here at the upper part of the axilla on the lateral wall, alright. If you pull this, you will find that this musculocutaneous nerve is piercing a muscle. You will find that this musculocutaneous nerve is piercing a muscle. Alright. This nerve is the, so you can identify that this nerve is the musculocutaneous nerve. Got my point? So one thing is done. Now, there are plenty of nerves close to this medial cord. Alright. Number one, medial pectoral nerve, medial cutaneous nerve of arm and forearm. And here you will get, this is axillary artery. Here will be the axillary artery. Remember these two joints in front of the third part of axillary artery. So this is the third part of axillary artery. Alright. So medial cord will be medial to the third part of axillary artery. Got my point? And there will be the vein. Here will be the vein. This here will be the axillary vein. Please change this. Hello. Change this blue sketch pen. So in between the axillary artery and axillary vein, there is lying the medial root of medial nerve along with its continuation, where from the three nerves come out. Number one, medial pectoral nerve, you cannot see it because it is a little higher up, alright. And then the medial cutaneous nerve arm and forearm. Remember, all these structures lies in between the gap of axillary artery and axillary vein. All these structures lie in relation to the axillary artery and axillary vein. And this ulnar nerve, this one is the ulnar nerve, alright. Ulnar nerve, though lies in between it, but it is in a more deeper plane. Ulnar nerve is in a more deeper plane. So in between these two, which two nerves will thin two nerves we will find, that is the medial cutaneous nerve arm and forearm. Forearm, medial cutaneous nerve of forearm is again in a superficial or frontal plane, whereas the medial cutaneous nerve of arm is in a deeper plane, but lying in between the axillary artery and axillary vein. Alright. Now if you lift up this axillary artery, axillary vein, if you lift up this structure, alright, what structures will remain there? Number one, medial cutaneous nerve of arm and forearm, of which forearm is in the anterior plane and arm is in the a little posterior plane. Alright. And if you pull this out, in the deeper plane, you will see the ulnar nerve is coming below it. And if you hold this median nerve also and pull it anteriorly, you will find the radial nerve is coming below it, just like this. This is the vein. This is the artery. Oh, sorry. Right. Anterior plane for medial cutaneous nerve arm, forearm, right, and a little deeper to it will be the ulnar nerve. So if you pull this towards your front, all right, what you will get? You will get that ulnar nerve is lying below it. This is ulnar nerve. If you pull it up, then you will see the ulnar nerve coming like this. Got my point? And with the ulnar nerve, if you pull it out, with the ulnar nerve, if you pull it out, then you will find the radial nerve is lying just like this, in a more deeper plane. This is the simple, most efficient understanding of the structures of the axilla. Alright, go to your dissection hall, whether I am present or not, you try this one, you will be able to identify all the nerve, and I am sure. Got my point? Alright, first you have to find this M pattern, pull it out. You will find one nerve is passing laterally, piercing the coracobrachialis. So this is the muscular cutaneous nerve, right? What you are holding is the medial nerve. So medial to it will be the medial cord that will lie in between the axillary artery and axillary vein, where from three nerves will come out. Number one, medial pectoral nerve that is very thin and upper. Then the medial cutaneous nerve of arm and forearm, of which the medial cutaneous nerve of forearm is in the anterior plane, medial cutaneous nerve of arm is in the posterior plane. Done? Then if you pull this out, you will find the ulnar nerve deeper to the axillary vein. If you hold out the whole structure, the artery, the nerve, within the ulnar nerve, you will find the radial nerve is passing through, because it is in the posterior plane. It will enter into the spinal groove. So it is posterior plane. Alright, you will find this is hanging like this. If you hold and pull it out, you will find the ulnar nerve. Then if you pull all this out, then you will find the radial nerve. Got my point? It is not that much easy. Only a tough thing is to distinguish between the medial cutaneous nerve of forearm and medial cutaneous nerve of arm. Remember, as it is medial cutaneous nerve of arm, so it will become subcutaneous earlier, but the medial cutaneous nerve of forearm will go downwards undivided. Got my point? So medial cutaneous nerve of arm will be tethered with the superficial tissue much more than the medial cutaneous nerve forearm, because it has to reach forearm. So it is not tugged with the subcutaneous tissue to pierce the deep fossa. Got my point? So medial cutaneous nerve arm will be tugged more to tethered more to the superficial tissue, whereas the medial cutaneous nerve of forearm is free, because it will pierce the subcutaneous tissue, that is the deep fossa, and the subcutaneous tissue in a more distal. Got my point? So you will not have, I don't think you will have any problem in identifying the structures as I have described. Alright. Now going by the walls of the axilla is a little, except the long thoracic nerve of Bell can be identified easily, musculocutaneous nerve also can be identified easily, but the ulnar nerve, radial nerve and the medial cutaneous nerve of arm and forearm, this you cannot identify clearly. Got my point? Now posterior divisions, that is the axillary nerve, upper subscapular, lower subscapular and thoracodorsal, if you find the posterior wall, if you can dissect the posterior wall, you will see in the upper part there is the axillary nerve, then the upper subscapular, lower subscapular and the thoracodorsal nerve. This is also easy if you can find the posterior wall properly. But dissection of posterior wall or lateral wall is not easy because it often cuts these nerves. Got my point? Okay, let me stop at this point. One thing is, I have told you something about the, yes or no? Plastic surgery can restructure. Plastic surgery can restructure your face or damaged part. Alright. Nowadays, plastic surgery has many disadvantages because the skin flap, either a rotational flap or an attached flap or a separated flap. Alright, full thickness or partial thickness flap. If you take suppose from thigh to put on your face, it often is not properly attached. So, repeated session of plastic surgery is to be taken. And for Indians, plastic surgery doesn't hold good for Indian people because for the foreign people, the subcutaneous tissue is very much enriched and vascularized. For Indians, it is not that much. So, in case of Indians, what we prescribe is a aesthetic medicine. What is aesthetic medicine? To use the electrotherapy to build up the muscle regions. Alright, you can use the electrotherapy to make your calf muscle rounded. You make your cheeks prominent, your malar prominent. You can either control these features. Got my point? So, this kind of application of the electrotherapy is known as the aesthetic medicine to beautify, to correct some deformities, some weakness and some facial features for beautification. Got my point? Okay, let me talk about the structures in the arm. No. Oh. Keep some extra sketch pens every day. This is ridiculous. No, I don't need the black. I need a red marker. Put some water into it. If you have some water, just put some water into it. একটু জল এর মধ্যে দাও না, a very little amount of water. এটার মধ্যে একটু জল দাও না, অল্প একটু জল দাও, খুলে একটু জল দাও। Brachials. Got it? ये चक्रवर्ती है, ये क्या है? चक्रवर्ती है। आजा आजा, थैंक यू। আচ্ছা, না না, আমাকে বন্ধ করে রাখতে হবে না। ওকে, থ্যাংক ইউ। হ্যাঁ, না একটু দিলে হয়।
শুকিয়ে গেছে স্যার,
একদম শুকিয়ে, একদম শুকিয়ে। ঠিক আছে,
বলছে
you make the colors accordingly for the muscles red, for the artery red, for the nerve green, all right, and the bone by blue outlines, by the blue outline. You see, this muscle is the teres major. Remember, teres major, the lateral border of scapula gives two facets of origin of teres minor, all right, but they move posterior to back, posterior to posterior in the supraspinatus, infraspinatus, on the posterolateral aspect of the humerus, that is on the greater trochanter. All right. So supraspinatus from above the scapula is on the impression for the supraspinatus, infraspinatus to the back to the infraspinatus impression, and the teres minor is also back to back for the lower portion of that articular impression. So supraspinatus, infraspinatus and teres minor all are back to back. Got my point? Now the teres major, the large head of teres major, all right, that is passing from back to front. It is not like this. This is back to front to be attached to the medial ridge of the intertubercular sulcus or bicipital groove. Got my point? This teres major is coming like this, but the teres minor is back to back. Got my supraspinatus, infraspinatus and teres minor is back to back, but the teres major is crossing the axilla to come in front to the medial border of the bicipital groove. Got my point? And you can see at the lower end of the long head of triceps that originates from the infratubercular infraglenoid tubercle, it will go behind this teres major. It will go behind this teres major. Got my point? So it is in the more posterior plane. It is more on the posterior plane. Long head and of triceps, sorry, long head of triceps, we can see while we dissect the scapular region. Got my point? Now, at the lower border of teres major, there is the formation of, there is the continuation of axillary artery as the brachial artery. As the lower border of teres major, we see the continuation of axillary artery as the brachial artery, as well as the basilic vein also joined with the two veni comitatis of the brachial artery to form the axillary vein. So, basilic vein joining with the two veni comitatis of the brachial artery at the lower border of teres major is continued above as the axillary vein. Is it clear? Got my point? Now, the brachial artery, now first try to understand the muscle plane, right? This is your biceps brachii. It has two heads. That is the long head that is coming from the supraglenoid tubercle, and the short head as a conjoint origin with the tip of the, at the tip of the coracoid process. Remember, coracobrachialis is medial, coracobrachialis is medial, and short head of biceps is lateral. At its origin, after it comes out of the origin, the short head of biceps is lateral and coracobrachialis is medial. Got my point? So these two heads, that is the short head and long head, the long head is passing intracapsularly but extra synovially. Intracapsularly but extra synovially. Got my point? And it is taking a synovial sheath around it, and it is getting inserted with the short head, not right at their occurrence. They come a little below, nearly upper third of the arm, they lie side by side, then they join with the lateral and medial head joint and form the fusiform belly of biceps brachii. Alright, and it gets inserted at the posterior aspect of the radial tuberosity. In the anterior aspect, there is the bursa that separates it to avoid the friction. Alright, it is like this. So, after forming the fusiform belly, the fibers twist. This was the fusimum belli. This is becoming as a tendon. Then it is twisting like this. Alright. So that the anterior fibers become lateral and posterior fibers become medial. Right. In this way, it is attaching to the posterior aspect of the radial tuberosity. Got my point? And you can see the supinator. This is the supinator muscle coming from the supinator crest of the ulna. All right, and it is holding the posterior surface as well as part of anterior surface. And when it contracts, you see the power of contraction and direction of contract. So this is contracting in this direction, and biceps is contracting in this direction. So what will happen? This thing will rotate like this. Got my point? So this is the action of biceps brachii, which is called the supination. Alright, so that's why biceps is called supinator longus. Biceps is called supinator longus. Is a supinator, you can call supinator muscle as the supinator brevis, but biceps is the supinator longus. Got my point? Just below the biceps, let us draw a cross section at the lower third of the arm. if you do a cross section near the lower end of the arm, right, what will you see? This is the skin, this is the superficial fascia, in which there is this is basilic vein, this is medial, this is lateral, this is the cephalic vein, alright, and this is the shaft of the humerus. Remember, shaft of the humerus in the upper part, there is a question often asked in the examination that what are the changes that occur at the mid-shaft region of humerus, alright. The upper cylindrical part of humerus becomes triangular in the lower part, alright, and there is insertion at the middle, there is insertion of the deltoid laterally and the insertion of coracotrachealis medially. Got my point? Then what happened? The brachial artery, which was medial, gradually comes to the front of the lower part of the arm. The median nerve, which was initially lateral to the brachial artery, will cross the artery from its front and goes to the medial aspect of the brachial artery. Got my point? Medial cutaneous nerve of arm and forearm, medial cutaneous nerve of arm pierces at the with superior ulnar collateral artery, also pierces the medial intramuscular septum at this region. Got my point? At the upper end, that is the medial part of the shaft, upper end of origin of the brachialis, there is the crossing of the median nerve. At that region, the median nerve crosses from lateral to medial aspect, and behind, just at this junction, behind, you will find the radial nerve in the spiral group with arteria profunda brachii. Got my point? There are 10 points. You will remember it, memorize it afterwards. Alright. Now you can understand this is the ulnar nerve, this is medial intermuscular septum, behind the medial epicondyle. This is the lateral intermuscular septum, right? Now in front of the lateral intermuscular septum, that is lateral supracondylar disc. In the upper two-third, there is the brachioradialis muscle, and the lower one-third is the extensor carpi radialis longus, and extensor carpi radialis brevis is a little below to the origin deep and origin of the extensor carpi radialis longus. That's why extensor carpi radialis longus and brevis, none of them are supplied above the elbow or near the elbow. These are supplied just below the elbow. Got my point? But brachioradialis gets a supply from the radial nerve out here. Got my point? And you can see this is the biceps brachii, the fusiform belly, and this is the brachialis muscle. And in between this musculocutaneous nerve is passing from medial to lateral, and becoming the lateral cutaneous nerve of forearm. This musculocutaneous nerve will form the lateral cutaneous nerve of forearm after crossing the elbow joint, right? And the radial nerve, which is in the post spiral group from medial to lateral like this, all right. Got my point? It comes in a relation in an intermuscular tunnel. This is an intermuscular tunnel. Outer there is brachioradialis, inner that is extensor carpi radialis longus, and more medially is the brachialis muscle. This radial nerve enters by piercing the lateral intermuscular septum and comes in the front. So radial nerve comes in the front 2 times of the arm, right? In the upper, first in the upper part before entering into the spiral group, then after piercing the lateral intermuscular septum, it again comes to the front in the intermuscular tunnel that is formed by the brachialis medially and the brachioradialis and extensor carpi radialis longus laterally. After that, it comes in relation to the lateral epicondyle of elbow joint, and it gives out the branches. Got my point? I will draw another figure for it. Now, what is the importance? You have to note. I'm sorry, I don't have any red ink. am not satisfied with these drawings because I don't have the colors. All right. Now you see, as the median nerve process, the brachial artery from the lateral to medial. All right. It is continued below, deep to the both head of pronator teres. It is continued below, deep to the both head of pronator teres. All right, the humeral head and the ulnar head. The medial nerve is passing deep to the both head of pronator teres. Now the brachial artery just 1 centimeter below the elbow joint is dividing into radial artery and ulnar artery. All right, this radial artery is giving rise to radial recurrent branch, which is anastomosing with the radial collateral branch from the arteria profunda brachiae. Right, this is one anastomosis. And from the medial aspect, there are two collateral arteries. One is the superior ulnar collateral artery and the inferior ulnar collateral artery. Right, this superior ulnar collateral artery is anastomosing with anterior ulnar recurrent branch. Superior ulnar collateral artery is anastomosing with anterior ulnar recurrent artery, and the inferior ulnar collateral artery is dividing into two branches. Number one is descending and another is the transverse branch. All right, inferior ulnar collateral artery is dividing into two branches. Number one transverse and one is the descending. All right, this descending branch anastomoses with the posterior ulnar recurrent artery. Anterior ulnar recurrent artery anastomoses with the superior ulnar collateral artery. So inferior ulnar collateral artery is anastomosing with the posterior ulnar collateral artery. Got my point? And this transverse branch is making anastomosis with the middle collateral branch of the arteria profunda brachiae. This one is the transverse branch. All right. This is anastomosing with the medial collateral branch of the arteria profunda brachiae. This completes your cubital anastomosis. Two questions often asked in the examination. Number one, what are the structural changes that occur in the mid-shaft region? Number two, what is the relation of the tendon of the biceps brachii, brachial artery and the median nerve? All right, you will always say from lateral to medial. Never say in many books nowadays it is written in the direction of medial to lateral. No, you should remember always it in relation to the lateral to medial. That is tendon of biceps brachii, A, artery, that is brachial artery, nerve, that is median nerve. Got my point? And remember, the median nerve goes deep to the both heads of the pronator teres, whereas the ulnar artery comes in between the two heads of the pronator teres. What I emphasize, the median nerve is entering into the forearm deep to the both heads of the pronator teres, whereas the ulnar artery is entering the forearm in between the two heads of the pronator teres. Got my point? Now, one thing else is the radial nerve that enters through the posterior part. I haven't drawn it because I don't have the time to explain you the posterior aspect of the arm. So I will complete it in the next class in a few minutes. Now a little about the actions of the muscles that I have described. What my point? Remember, coracobrachialis is analogous to an adductor muscle as in the limb. We have extensor compartment, flexor compartment, and medially there is the adductor compartment in the limb. Right? This coracobrachialis is analogous with the adductor muscle of the upper limb. Why? Because it is neither inserted in the posterior compartment nor inserted in the anterior compartment, but it pierces the medial intermuscular septum and it has an intermediate insertion in between the anterior aspect and posterior aspect of the humerus. Right? Though in human being, this adduction effect of the coracobrachialis is not that much significant, but it is a weak flexor of, as the adductors are also weak flexor, thoracobrachialis is also a weak flexor supplied by the musculocutaneous nerve before piercing the muscle. Right? You will come to know that thoracobrachialis actually have 3 heads. Number 1, both are fused. Both origins are fused at the tip of the thoracoprocess, and in between these 2 fusion, the musculocutaneous nerve fuses. So it has 2 heads, and below, you know the supracondylate process, 5 centimeter above the medial epicondyle from the anteromedial surface of the humerus, there is a curved supracondylate process to which a ligament called the Struthers ligament is attached to the medial epicondyle. Right? This Struthers ligament gives the origin of 3rd head of thoracobrachialis. This Struthers ligament, which comes from the supracondylate process to the medial epicondyle. All right, and the part is joined by the Struthers ligament, deep to which can pass both the brachial artery and the median nerve. And if there is compression at this, there will be cubital syndrome. I will tell you later on. Right, biceps, as I have told you, it is the flexor, brachialis, it is also the flexor. Remember, only bicep flexes best in supination. Bicep flexes best in supinator. So that's why it is called the supinator longus, supplied by the musculocutaneous nerve. And brachialis can flex both in supination and in flexion also. So brachialis is the main supinator of the elbow joint. So biceps, brachialis. I haven't mentioned deltoid as this will be covered with the scapular region. Alright, and you know, just opposite the insertion of thoracobrachialis, there is a V-shaped irregular impression for the insertion of the deltoid muscle. As I will draw the upper quadricular lower triangular space, next day I will show you how the axillary nerve is coming and its anterior branch supplying the anterior part of the deltoid, posterior part supplying the posterior part of the deltoid. One branch is going to supply the teres minor, and there is the upper lateral cutaneous nerve of arm. Upper lateral cutaneous nerve of arm. Lower lateral cutaneous nerve of arm is given by radial nerve, and the lateral cutaneous nerve of forearm is the continuation of musculocutaneous nerve. Alright, let me conclude here. I will continue the discussion starting from the axilla in the posterior aspect of the arm. Alright, thank you all. One thing is that when you are going to palpate the brachial artery, always try to first ask the patient, or you just flex his or her arm to find the tendon of the biceps brachiae, just at the elbow crease. Right? If you move medially, you will find the brachial artery. Don't miss it, because for palpation of the deep artery, brachial artery is a very important thing. And we put the diaphragm of the stethoscope over here to measure the blood pressure. Got my point? Alright. Thank you very much for patient hearing.